Good evening, class. We're going to spend a few minutes tonight talking about the healthcare workforce market. Before we jump into that, we've spent a few sessions talking about supply and demand, productions, costs, demand for healthcare goods and services. And just always remember that demand is a willingness to seek and to pay for a service. So it's willingness, ability to both seek and pay for a service. And one thing that you will always you hear me mention it multiple times probably is when we're looking at the model of supply and demand, you're concerned about two things: prices on the vertical, quantities on the horizontal, and also it's a function of the marketplace and the supply and demand for most goods and services. And Adam Smith, of course, is the one that said the invisible hand forces markets to equilibrium, and that's equilibrium price and equilibrium quantity. And that, to some extent, happens in healthcare too. Maybe not to the extent that it happens in a completely competitive or a perfectly competitive market, but it does in some instance apply to healthcare. And as you go out into the real world, especially if you want to get into, again, to the healthcare market, one of the things that you just need to understand is, and we've talked about it on multiple occasions, is providers or a firm just in general produces goods and services to make a profit. I mean, that's what drives the production of goods and services. Firms take inputs, they turn them into outputs, and they do it for one reason only: that's to make a profit. And doesn't matter, we've talked about both sides of the financial coin, and it doesn't really matter at some point which side of that financial coin you're on, whether you're on the payer side or whether you're on the provider side, because the basic fundamentals of microeconomics apply to both sides of that financial coin. And two things I want to stress before we kind of jump into the healthcare workforce market is that again, whether you end up on a health plan or whether you end up on the provider side of the house, you're going to be asked to do some analytical work somewhere along the way, because you're going to have to justify, especially if you get into management, you're going to have to justify the workforce that reports to you, or your team that reports to you. And if you have to justify to either your immediate supervisor, or maybe situation that I've been in multiple times, I'm justifying requirements for a team, either to a CEO, a CFO, chief actuary, and it all comes back to return on investment. And that's first question they always ask me. Okay, you're asking for a piece of software, you're asking for a new automation system, you're asking for additional FTEs. And the first thing, again, they always ask me, what's that return on investment? And it's fairly easy to calculate once you get the number. So the return on investment, it's, again, fairly simple calculation. In the numerator, it's the benefits minus the cost. And in the denominator, it's the cost. So at that point, you are talking about taking in, trying to calculate. So you're going to have to estimate what the benefits are going to be. In a case that when I worked at Blue Cross Blue Shield, my benefits were dollars that the payment integrity team were bringing back in the door. And it got to the point that I had a pretty good feel for it. In most of my team, it was either comprised of analysts or comprised of clinicians, and in most cases they were nurses, but clinicians never the same. And nevertheless, but it was always one of those two. And my benefit, or my benefit of bringing on a new nurse, once that individual was trained and up and going, usually took about 6 to 9 months. And at some point, they were going to be bringing in somewhere between $2 and $3 million. So that's my benefit. The cost of that nurse, depending on experience and the market, and especially the job market in Buffalo, was going to be somewhere between $100,000 and $150,000, and that included benefits. And so that's my cost. So I'm subtracting my benefit. I'm taking my benefits, subtracting the cost, turn around, dividing my cost, and that's where I'm coming up with my return on investment. And my return on investment is always pretty steady. That didn't, if I couldn't hit a specific return on investment, or I didn't think I could, I wouldn't even go to the CFO and ask for additional FTEs. And then the other piece of information, or the other formula that you will use a lot, again, depending on what side you're on, it's the expenditure, formula, or the revenue formula. And that's nothing more than the summations of P to the I times Q to the I. And you sum it across all of the goods and services that, you're generating, or that you're selling, or you're purchasing. And that becomes either your total expenditure or the total revenue for maybe your team, or if you're on the provider side, it's the total revenue that you're going to be bringing in from health plans, or bringing in from payers, could be government payers. And if you're on the health plan side, it's going to be either the revenue that the sales team is generated by selling the health plan's benefit packages to employer groups, or it's going to be the expenditures for a given functional area. And again, it's all based on prices and quantities. So what drives the world on not only healthcare, but the world, on commerce and industry, it's nothing. You can distill it down to nothing more than prices and quantities. So at this point, we're going to jump in, and I think even Dewar has her text in the book structured this way, focusing on physicians and focusing on nurses. Now, there's a lot of other healthcare resources as far as markets for healthcare. The workforce. You've got clericals, you've got technicians, you've got some pharmacists, you've got some hourly employees, you've got some exempt salary employees. So there's a lot of other supporting cast, but the supporting cast, if you think back when we were talking about production and cost, in the short run especially, what is it that you can change most readily in the short run? And that's labor, and especially labor in this supporting cast. So we're going to focus on this discussion on the first part, focus on physicians, and the second part, we're going to focus on nurses, because those are the two pieces of the labor force that are probably the most problematic to not only forecast the need for, but to manage as you go forward, depending again on which side of that financial coin you're on. And if you're kind of following along the slides that I've loaded out onto Canvas, the first bullet says, in the market for physicians, it's talking about high monetary costs and psychological costs versus ability to charge higher economic rents via higher fees when compared to other market economies. And that's one of the drivers that determines whether individuals decide to go the route of being a physician, or maybe the route of going the route of being a nurse, or maybe they don't even want to be on the patient care side. Maybe they want to be on the health plan side, and they want to be an analyst or an actuary or a network management person. So all of these, it's the salaries that individuals are looking for drives their desire to either go into patient care or go into some other aspect of healthcare. And when you talk about economic rents, it's the extra amount earned by a resource, and typically they talk about land, labor, and capital by virtue of its present use. And then a second definition, it's extra unearned income above economically and socially accepted charges. And if you stop and think about it a few minutes, that's basically what you have in the healthcare field, especially on the physician side of the house. Nurses now are demanding, the supply and demand is a little out of whack on nurses, just like it is physicians. So they're able to generate some economic rents. Lawyers can generate economic rents. Computer, somebody in the computer field, especially if you've got the skills to get in the AI world, you're going to generate some economic rents there also. And then, if you look at the physician salaries, and I, quickly looked up one in 2019, the median wage for a physician, and it was across all specialties, was $206,000 and some change. So not a bad salary, but as a physician, you're going to weigh that against the amount of investment in your human capital that you either spent or attained by going undergraduate, going to medical school, residency, internship. There's just a lot of education. And then if you decide you want to specialize like cardiology or orthopedics or neurology or neonatal care, there could be some additional years of study that you have to go through and years of experience that you have to gain. And then the second bullet talks about adequacy of supply versus the community's demand for services. And that's where in certain communities you end up with surpluses and shortages. It's, you think about, go back to your microeconomics, we went through, or I'm hoping you went through the discussion of surpluses and shortages. Surpluses is, when supply is greater than demand, and shortage is when the supply is less than the demand. And so that's what's driving a lot of different supply and demand characteristics across a lot of different physician specialties, and it depends on the community you're in. Lived in San Diego for a number of years, and a lot of Southern California especially is dominated by the military. You've got Camp Pendleton, the Marines, kind of in the north part of San Diego County. In the southern part of the county, you've got the Navy, and you've got some naval, you've got you've got the Naval Air Station there, and just a lot of military families in that Southern California area. And the Naval Medical Center or the Naval Hospital at Camp Pendleton, both of them hired a lot of EMTs because they had a lot of young families and they needed a lot of tonsillectomies. And these EMTs, when they put in the years in the military and they got out, they loved San Diego. They wanted to stay there. But as they more and more got out, you had a kind of a shrinkage in the number of individuals that needed tonsillectomies, especially. And so you ended up with, unfortunately, a surplus of EMTs. A lot of those individuals had to leave and leave San Diego and go somewhere else where they could open a practice and generate the income that they desired for their families. If I'm talking about Atlanta, from my perspective, there must be a shortage. I can't get in to see my primary care doc whenever I want to. And at that point, we ask ourselves the question, does access equal shortage, or is it more tied to just inefficiency in a doctor's office? I kind of lean more toward the inefficiency than a shortage, but I know it's going to vary from one community to the next. And then the supply of physicians is a function of individual career decisions and public policies. And always remember that in the physician space, a lot of it's driven by public policy. How much of the teaching research facilities and how much of the medical school facilities is the public policy subsidizing? What does the AMA think about the supply and demand of physicians? How many medical school slots are there? If you look at Meharry, the medical college, I don't know for sure, but they're going to be only allocating X number of medical school slots for any given year. So what happens is between the AMA and public policy, you're actually controlling the supply of physicians, and in controlling the supply of physicians, at least in theory, you control the price of the goods and services that those physicians can supply consuming public. And if you can control the price, supply, and get a higher price, it's going to be more lucrative for individuals to enter and try to attain a degree as a physician. And then, as I talked earlier, we've got Adam Smith, and it's his invisible hand of supply and demand for physicians and medical, versus medical associations. Is the invisible hand? How does it, size up with state and federal regulations, and the number of medical schools and teaching research hospitals we have, and the number of slots for not only medical students in medical schools, but slots in internships and residencies. So there are a lot of factors out there driving or impacting the supply of physicians. One thing that a lot of individuals, especially economists, have trouble getting their arms around is, how do you measure quality? And what does it look like from a quantity perspective when you're out there trying to measure the impact of supply and demand, and especially the impact of supply and demand on access rates. And physician supply analysis basis, it's based on statistical analysis by region. And one thing that you're looking at, and I'll go back to my days, and this is when I worked at Health Net. If you think about a health plan, if you're on the health plan side, health plans, when they develop a network, so they develop a network for commercial, they've got a network for Medicare Advantage, they may have a network for Medicaid, may have one for TRICARE, they may have one, depending on the city you're in, for some overflow from the VA. They have network adequacy metrics that they have to meet. And it's, based on, it's a state and federal level on these network adequacy metrics that they have to meet. And where it is really difficult in some areas are in the subspecialties, say cardiology, neurology, orthopedics. You end up having to have, again, depending on the state, you have to have certain network adequacy metrics for each individual specialty or subspecialty, depending on how the state, or maybe it's a federal mandate, depends on how they roll it out there. And when I was at Health Net, I kind of took a little different spin on it. Rather than, most health plans will say, well, we need X number of physicians for each 1,000 enrollees or each 1,000 members. I took a little different approach, and I developed a network sizing model. And it was based on information I got from the CDC, from the Kaiser Foundation, from the Robert Wood Johnson Foundation, got some information from CMS. And I based it on how productive a given subspecialty or given specialty of a physician was. And if it was a physician that only saw patients in an office setting, then I didn't worry about the surgical piece of it. But if it was, say, an orthopod that's completing surgeries, they're doing some office visits, they're doing some hospital rounds, I also factored all of that in, and I based this network sizing model on the total number of goods and services, we'll say, that the health plan could buy from physicians in a given geographical area. And most people really like the model because it was actually driven by supply and demand, or the factors that appear to be driving supply and demand. If you kind of look at the second page of the notes, it says shortage implies the quantity supplied is less than the quantity demanded at a given price. Remember, demand and supply, price over here, quantity down here on the horizontal. And if you're talking about at a given price, a shortage implies the quantity supplied is less than quantity demand. And DeWars gets into vacancy rates, and even she says vacancy rates are hard to estimate. Relative earnings to relative returns to training and policy analysis. And so there's kind of two vacancy rates that I've in the past looked at. One vacancy rate is on the provider side, and it is specifically driven by, and we'll get into it a little later down through here, but it's specifically driven by when providers leave an area, it creates a vacancy in the medical practice that they were employed in. Same thing with nurses. Everybody, policy especially, is concerned about vacancy rates not only on the physician side, but on the nursing side. And policy especially is concerned about vacancy rates if you're talking about underserved areas. Think about, Appalachia. So think about East Kentucky, East Tennessee, the western part of the Carolinas, western, part of Virginia, even get up into West Virginia, kind of the way the Appalachia, comes down through there. There are actually places in North Carolina, closer to the central part of the state, or even, over on the eastern, East Coast part of North Carolina that have issues with the number of providers in that given area. So, it's tough to get providers to go there. And once you get providers there and start to build up a network and start to build up capacity, then what happens if all of a sudden, one or two, especially if you've got, orthopedics, or you've got maybe pediatricians, if they start leaving and going in other directions, it creates these vacancy rates. And it's really difficult, not only in the health plans to build network, but it's really difficult on the consumers in those particular areas. And one thing that you're looking at, especially when it's in a provider setting, and let's say it's a primary care group. So it's a primary care group, and let's say they've got a dozen physicians in the primary care group. Go back to I think we talked about it on the production side when you were talking about the marginal product of labor. The marginal product of labor helps an office manager. So most of these physician groups have an office manager that oversees kind of the labor part of it, and the operations piece and the flow of patients in and to be seen and the flow back out the door. And a lot of times when you're in a physician's office, it's not that you don't have the right number of physicians, it's that you're not seeing the right distributions of patients in an hour. I mean, think about it. If you're seeing 3 patients in an hour, you're seeing, a patient about every 20 minutes. But what could happen if you're seeing 5 patients an hour? Now you're seeing one every 12 minutes. And you can generate a lot more goods and services by seeing 5 patients an hour than you can 3 patients an hour. That takes some staffing, and you have to have a well-oiled machine for that to work. But I have witnessed it in a number of provider offices where they can take, they're seeing 2 and 3 patients an hour. They revisit their staffing, start looking at that marginal product of labor, and all of a sudden they can get it up to 5 patients an hour and doing a very efficient job in seeing 5 patients an hour. And then earning differences may reflect compensation differentials. So again, providers, for the most part, the price the provider receives for the goods and services that they produce is driven either by, if it's Medicare, CMS has a fee schedule, Medicaid has a fee schedule, TRICARE has a fee schedule, or on the commercial side, or even if you're talking about Medicare Advantage and Medicaid, if you've got some health plans that are in the business, or even on the TRICARE side, they're going out and they are contracting with providers. They will pay this number of dollars for this service, and the service is driven by CPT code. And the providers, unfortunately, can't adjust their pricing except once a year. Those contracts are evergreen contracts, and they run from January the 1st to December the 31st. And, I've seen 1 or 2 that didn't, but the majority of the time, those contracts are that rate's negotiated back here October, November, December, goes into effect January, and that rate, let's say for a 99213, the intermediate office visit, that rate's $60. $60 a visit. So provider can't, and it doesn't matter what happens to the provider's cost, they're not going to get another adjustment to that CPT code, to that intermediate office visit, until it rolls around for a year and comes back and it's renegotiated. So you're pretty much locked in on the rates that you as a provider can establish. And I guess one of the last bullets, I'm kind of skipping a couple of bullets, but that last bullet on the page, it says higher rates of return may indicate dynamic shortages, and that's true. If you're in an area where there's a shortage of physicians, again, shortage of physicians, you got that downward sloping demand curve, the upward sloping supply curve, shortage of physicians, that supply curve starts to shift backwards and to the left. And what happens? Price goes up. So if you're in an area where there are dynamic shortages, especially as a physician, you can, through negotiation strategies, you can drive a higher rate with the health plan that you're negotiating with. Let's see. Market imperfections at the top of the third page. So you're talking about market imperfections driven by lags in market equilibrium and expected rates of return. And what the text that Dora's talking about there is such a lag. So let's say that public policy, this is 2023. Let's say they've been doing some analytical research, and if the House of Representative ever gets anybody there that's in charge and kind of start moving things through the system, there is a potential for public policy to start, if they think there's a shortage now, and they're looking at ages of physicians and how they're going to age out and when they're going to retire. And so they got everything, scattered by age, sex, cells, and they're looking at it and trying to figure out, forecast what the supply is going to be in X number of years ahead. So in 2023, if you decide to, in public policy, to subsidize more slots in medical schools, subsidize more in the teaching research facilities to boost your supply of physicians, you may be looking at 10 years down the road, because at least you're looking at 4 years down the road for medical school, at least a year for a residency, at least a year for an internship. So now you're at 6. And let's say you want some specialized training, you may be another 7 or 8. That's on top of individuals just going in as a freshman year trying to get an undergraduate degree. So that's what the authors talk about in the text about the lag. It is extremely difficult. And what you've seen historically is this kind of oscillation, ebbs and flows. Shortage, you have a shortage of physicians, now you got a surplus, and it's back to shortage again. And that's because of the lag and the amount of time and amount of effort and time and cost spent in training. However, it takes a long time to train a highly effective, highly capable physician. And higher rates of return on training indicate shortages. Again, supplies shifting, prices going up. What happens in a shortage on physicians, and it's across all disciplines. It's not just the surgical physicians, or it's not just the orthopods or the cardiologists or the neurologists. You will see these shortages across all disciplines. And then the authors talk about barriers to entry. So typically you think about barriers to entry, you hear that when they talk about, monopolies or oligopolies and things like that, but there are barriers to entry. And the AMA it's almost like a profit maximization driver. And AMA is the American Medical Association, if you're not familiar with that nomenclature. But it's almost like a guild and apprenticeship type situation where you've got to go to medical school, you've got to do interns, residencies, maybe get some specialized training. And they're trying to say that internship, we're driving quality. We're turning out some highly qualified individuals. So entry restrictions and price controls, while quality is really difficult to measure, that's what's going to drive and going to help keep the price up on the physician side, and at least hopefully entice the best and the brightest to go to medical school, and so that the AMA can help churn out these high quality physicians. Public policy responses to physician shortages or gluts of physicians. And again, it goes back to the legs. These, serious, significant oscillations up and down. If you look at historically year over year. Then the authors talk about not homogeneous specialties, residencies in internal medicine, cardiology, geriatrics. You get higher earnings, you get prestige, more prestige. You get regular hours. The physician I used in San Diego was head of the internal medicine department at University of California in San Diego. I mean, a very prestigious university, especially when it came to churning out physicians and high quality physicians, and a lot of their residency and intern programs. They were almost right across the street from the VA facility in San Diego. So it was a highly prestigious group. And he was internal medicine, but he specialized in geriatrics. So, I was by far, when I was there in San Diego, one of his youngest patients, because he had a geriatric specialty, and he was seeing a lot of elderly patients. But it is, the more training you have, and the more specialized you can get in the medical profession, it does drive higher earnings and prestige. And you're not working so many night shifts, and you're not working weekends. You're seeing patients, 8 to 5, 8 to 6 on Monday through Friday. And you may have to cover a few weekends here and there, but it's not like you're working every weekend. Subsidies reduce private cost of training. And again, it goes back to public policy. How much of a subsidy is the public policy going to subsidize when it comes to training? Individual training decisions, and it goes back to what we've talked about in the past. It goes back to, decisions at the margin. Or you want to talk about the marginal decision rule. So if you're graduating from college with a 4-year degree and you're trying to figure out what to do, and you start looking at, going to medical school, and as long as that marginal return is, is greater than your marginal cost, it's going to look like a great deal, and you're going to go for it. And hopefully, again, AMA through the medical schools and through public policy is trying to entice the best and the brightest to go into the medical, into a medical discipline. And when we got back to, I told you we'd circle back around and get back to vacancy rates. And on the vacancy rates, there's 3 impacts on vacancy rates. And this is going to be, whether it's a physician, and we'll talk about vacancy rates in a few minutes, in the nursing profession too. But with vacancy rates, there's hard cost. And that's the cost of having to reach out and, go through a headhunter and bring in and identify and interview and bring in a new physician to take the one's place that's left. There's also the soft cost, because it's going to take that new physician a while to get up to speed, to understand the process, to become as efficient as they need to. So that's kind of the soft cost. And then lastly, kind of on the cost side, there are these lost opportunities, because you're losing out on accepting new patients. Maybe you're short a physician or two, and especially if it's a primary care clinic, short a physician or two, and now all of a sudden, because you're trying to fill staff positions, and all of these doctors' offices have staff to patient ratios that they have to meet and have to adhere to. Some driven by state and federal mandates, some are just driven by the physician's office themselves. But you're going to lose opportunities, because health plans are going to look at you and say, well, we're not going to assign any other patients to you because you don't have the proper physician to patient staffing ratio. Let's see what we've got left here. Go through this last page, and then we'll flip over to the nursing piece. Public policy alternatives, underserved geographic areas, CMS, especially on an elderly population, CMS on both the elderly population and Medicaid population, they will They will continually bump their fee schedules higher to ensure that they have coverage for the elderly population and the Medicaid population. But um, individuals, if you graduate with, from medical school and do your residency and internship, maybe um, a lot of these public policies, and maybe it's through your residency and internship. If you go to work, say in an underserved area, let's say Appalachia, so you go to work in Eastern Kentucky for X number of years, they will forgive all of the debt that you incurred while you were in medical school. Uh, Military and the VA have programs that, similar types of programs. You're in the military and you decide you want to go to medical school, and they will finance your medical degree. And the military, contrary to what a lot of people think, they get some really good physicians in the military. They do have access to some of the best and brightest physicians around. May not be the most efficient, but as far as capability, they're extremely capable. And if you'll serve X number of years in the military, they'll pay for your, medical school. Contractual arrangements with MCOs impact the distribution of physicians. And that goes back to network adequacy. A healthcare managed care organization, which is an MCO, or a health plan, if you'd rather use that terminology, again, they have network adequacy that they have to meet, or they can't sell health. They can't sell the benefit plans without an adequate network. And the rates drive, or the location in which you're trying to develop that network are going to drive the rates. If you're in an area where there's a lot of competition among physicians and there's plenty of, on the supply side of physicians, health plans can squeeze. On the contract side, they can squeeze the prices that they're willing to pay a physician. If you turn around and I'll take the high desert in Southern California, so you're up toward Barstow and a lot of that area there that's sparsely populated, and a lot of physicians don't want to work there. But if you are a physician and you do decide to work there, you're in an underserved area, you can drive those rates once you get there. Age of physician impacts the distribution of physicians. You're talking about, benefits and wage structure and workday and training requirements. And that's what you run into with new physicians that are coming out, and they're trying to join a established practice. And what do you think happens to that newbie that joins that established practice? They're going to get the absolute worst work schedule of the bunch, because the others in that practice have been there. They've paid their dues, and they expect the newbie to pay their dues also. Inability to accurately forecast the supply and demand of physicians, and that's where you end up with the rub in public policy and CMS decisions. Medical schools have kind of stabilized over the last few years, so I think it's going to make it easier to forecast the supply and demand of healthcare services going forward and the number of physicians. Now, the thing that can impact the access and the number of physicians you have is we've got an aging population, and it's what do the numbers say, that in the last 20% of your life you use 80% of your services, or you incur 80% of your healthcare costs. So that's what they're looking at when they're trying to forecast the supply of physicians going forward. Economists and health planners are at odds on forecasting supply and demand of physicians. Well, sure, economists, we're at odds with everybody. It's just not the health planners. I mean, economists, we're developing our models. We're generating numbers, and a lot of times those numbers don't make sense to health planners. A lot of times they don't make sense to policymakers. But that's what economists do, and without economic analysis, it's going to be extremely difficult to ensure that we're going to have an adequate supply of at least on the physician side of the healthcare workers. I'm going to stop there, and when I come back, we're going to talk about the health plan or at least the supply on the nursing side of the house. Talk to everybody in a few minutes.